Welcome to Mic'd Up with Chiro Up. You've got Tim and Brandon today. This is a fun podcast based on subscriber and listener feedback. One of the things that we've heard frequently over the last several months is to go over one of the common things that is causing issues in chiropractic practice, which fortunately, I guess, is not clinical. It's actually based on patient compliance. So just like everything else we do, we want to talk about patient compliance, but we also want to weave in a clinical twist associated with that with our solutions. So today we're going to do that. So once again, welcome to another podcast. Thanks for joining us again. Today we're going to dig into something that really every chiropractor, whether you're seeing 5 patients a day or 50 patients a day, you've dealt with this. And this is the common practice villain called patient compliance. Let me be clear, I'm not here to pitch you on some kind of system. There really is no system to improve your patient compliance that works for all chiropractic practice, that works on every single patient, because every patient, every situation is a touch unique. But let's create some scalable systems in this conversation today that are going to help you succeed with this common villain. Now, that does not mean that we need to change our mission. We're always going to deliver efficient, reliable, cost-effective care. However, when we can do all those things really well, it still doesn't mean the patient's going to come back. So we can do everything well clinically. We can get our message across quickly. However, is that patient buy-in, is that patient understanding of their condition going to be enough that first visit carries you through the rest of your treatment plan? That's really where today's episode kind of comes in and merges those two things, the clinical aspect versus the psychological aspect. We really want to focus on not only understanding the psychology of the patient, but also create that framework that's going to help your patients hear you, trust you, and really ultimately comply with your expertise. Now, I did have to give Tim a little bit of homework here. He does not know this yet. However, and I don't know if I've ever even said this out loud. I have 1 C in chiropractic college.
The rest were D's?
The rest were D's. I think I think you do have to get a C or above. I don't remember, but I have 1 C in chiropractic college, and it was the absolute last class of the last final of my Tri-10, experience, and it was psychology. And so one of the unique things, or the things that I think is so funny about that, is that while I pride myself, as I'm sure you pride yourself, on being a great clinician, I would say that now, 15 years out, psychology really encompasses 50% of my office visit. I mean, what would you say to that?
Well, I think it's interwoven with 90% of it, that, yeah, if we can't see where the patient is coming from, understand their yellow flags, understand their background, it's a hard time to connect.
So these two topics, now I don't normally give Tim any kind of lead time on the podcast, meaning we sit down, I have questions, and we just go through those questions. However, I did give you a little bit of lead time because I had to do a little bit of homework on this. Let's talk about 2 topics: cognitive dissonance, which is really a mismatch between what our patients say and what they do. And then the second one being post-decision dissonance, which is, in layman's terms, buyer's remorse. So we both researched this over the last week, and I want to pose to you a couple questions, and I want to go through a series of solutions that you can implement into your practice, because really these concepts can change the way you communicate with your patients. And really, it's not just what you say, but also how and when you say it during your first visit, during that second visit, throughout that treatment plan, that's really going to help decrease the amount of patients leaving your practice, or another way of saying that would be increase your patient compliance. So Tim's going to help me make this a little more actionable. Together, we're going to break down several ways we use our clinical experience to reduce patient regret, to increase compliance, and keep patients committed to the care they need. Because, really when I look at it, compliance is a two-way street. And in the absence of clear communication between you and your patients, patients are going to make stuff up. They don't know when they're supposed to come back. They only, retain 10% of what we tell them. So we have to make sure that we say the right things, we do the right things, so we can avoid that buyer's remorse. And I think that's one of the hardest things we have to do in practice, because we're not Jedis at that. We're not experts at that. And we're going to go over a couple scenarios on situations where patients could kind of trigger a little bit of doubt in you. And we need to make sure that we use our clinical outcomes. We use our education. We use probably one of the biggest pieces is setting realistic expectations to make sure that they understand what we're going to do, they understand what they're responsible for, and that the goals we're about to set. Now, I want to lay out a little bit of a framework because we don't talk about this very much, but this is very important for this conversation. So Tim and I have a practice. We have another associate chiropractor in our area, or in our practice. We see about 65 new patients monthly. We average about 1,200 visits monthly. We're not a factory style high volume practice, but also we don't sit down. We're a very busy practice. But the reason I bring that up is because when we are there, we're moving. We have to have systems in place. However, we do have one distinct advantage that when I talk to other chiropractic practices on where their patients come from versus where ours come from, and that nearly all of our referrals come from medical providers or other patients. And I say that because it filters into this, is that we really don't do any external marketing, not because it doesn't work, it's just because we don't do that in a more of an established practice. And also it also brings in a less engaged patient. And I think this is where it really helps us in our first visit or two, is we don't have to spew out everything that we do in practice because they're already in a trustworthy relationship because they're referred by someone who they trust. Now, if you don't do medical marketing, make sure you check out all that information in Chiro. There's some awesome webinars on how to do that, how to get that started in your practice. It's something that's really grown our practice into hiring associates. I think that's something that we can all hopefully incorporate into our practice at many different levels, which we talk about in those webinars. All of our webinars are on the chiropractic.com webpage in the resources tab at the very top. All right, that was my intro, Tim. Let's kind of jump into the podcast. But first off, I guess, welcome back. We haven't heard from you in a while.
Yeah, awesome to be back. I always enjoy being on the show, especially when you give me homework, those sort of things. I had one question, though, based on that psychology thing. Was that part of a structured curriculum, or was that assessment kind of extra for you?
Yeah, I had to sit down with a psychologist. I laid on a couch for once a week for an hour. I don't know the purpose.
Yeah, we can probably make some assessments. So I appreciate the homework you gave me. Give me something well outside my wheelhouse. What is cognitive dissonance? And basically, what I came up with my research was that your patient's actions don't align with their intentions or their beliefs. And that can be in two levels. It can be superficial, to where their stated beliefs just don't have, they're giving you lip service. There's a lack of motivation. Or it could be that whatever they're saying conflicts with their deep-seated beliefs or values. So it can go a couple of different ways. And this comes out in practice where patients say, hey, doc, I'm finally serious about getting healthy again. I'll do whatever you tell me. And then they skip their exercises and don't show up for their next 3 visits. In fact, that's one of the 6 most frustrating patients that we outlined a couple of years ago. Their belief is that they care about their health, but their behavior says something else. And what you'll see is they'll downplay their exercises. Yeah, I tried them once, but I'm really busy. Or they question your plan, saying after 2 visits, I'm not sure if I'm feeling any better. Or they're looking for passive care. This is a common one, that a patient expects you and they come in your office and breathe the magic air that's in your office and they're just going to get better. Can't you just adjust me? Why do I have to be a part of this process?
So sorry to interrupt. So this is kind of what I was going to at the very beginning, is that to overcome this cognitive dissonance, it's not so much the treatment. It's not so much what we do. It's, can you match the treatment with their identity? Meaning, did we actually explain what's going on, why it's going on, and how it's going to help them? Because otherwise, the psychology is going to interrupt. So, if someone comes in and says, I'm too busy doing my exercises, you have to go back to them and say, listen, if you value independence and you don't have much time and money and you don't want to go 4 times a week or sorry, 3 times a week for 4 weeks to PT, these exercises are your best shot at staying off the surgeon's table. So kind of morphing it into their wants and needs. One of the things that, and I know I brought him up before, but a mentor of mine, Mark Maher, always said, be an easy place to fail. And the reason he said that is that unfortunately, when people do get out of pain, they stop doing everything that got them out of pain. And if the next time they come in, you rub it in their face and say, ha, you didn't do your exercise. You didn't do what I said. Now you have to come back in and see me. They're probably not coming back in because you're going against, their hobbies, their habits, their sports, their habits. You have essentially the way they sit in the car, the way they, sleep. Sometimes they can't break those habits. So if we're an easy place to fail, then they're going to be confident in coming back in that we're not going to rub their nose in it, and we're just going to go about getting down to business and solving it again.
Yeah, definitely. We all have goals and want to achieve things and are willing to endure a little bit of discomfort, but we run from real pain if you don't see that outcome. So I think one of our goals is to address either the superficial or the deep-seated issue here. Superficially, from a motivation standpoint, just saying, hey, let's get moving. Here's the good things that are going to happen. And sometimes even deeper, changing their beliefs, and that comes through education. So our job as teachers or doctors is to motivate and educate people. And that's not solely our responsibility to solve the patient. It's our responsibility to motivate and educate. But patients need to know that you're involved in this process too. When it comes to the work, you're the one who's getting the homework. I'm showing you what to do. And when patients understand their condition, at least on the surface as well as you do, they're a lot more likely to engage in care, to do their exercises, to follow through their treatment plans. That you've always said an educated patient is a compliant patient. Yes, knowledge definitely creates buy-in. And I think one possible reason that chiropractors deal with cognitive dissonance is because of non-compliance and misaligned expectations. So how do you set those expectations right out of the gate?
That's a good question. There's a lot of different things based on that really first visit is when we're going to kind of set the ground rules for the relationship. As you know, is that the way a relationship starts is the way it ends. If someone's late to their first appointment and not really listening to you on their phone, when they come in, it's not going to work very well. But let's get down to this. That's kind of one of the hardest things to do because, people, for the vast majority of people, especially in the last couple of years, they see stuff on the internet or on TikTok, and they're expecting this one quick adjustment to fix years of degeneration or a problem. And unfortunately, when reality doesn't match that, regret is going to creep in. That instant thought of, oh, I thought you were going to do X and I was going to feel this much better and I was going to do a cartwheel out of your office. So I think there's a couple things that I'd like to cover in my first visit. The first one is 100% to set clear expectations. That a lot of patients are going to expect manipulation to solve all their problems. And while manipulation is a powerful tool, unfortunately, we can't clear, years of degeneration. We can't magically heal torn tissue. So we're kind of explaining what manipulation is and what it's not. I also explain what I can treat and what I can't treat. If it's something that I'm not very good at treating or it's going to take a very long time and doesn't fit within my practice theme, then I'm not going to treat it. I probably spend more time treating shoulders than the average chiropractor. It's just something that I enjoy doing. However, with that being said, if someone has a frozen shoulder, I don't treat them. And it's not because I can't. It's a long process. It's not something I enjoy treating, so I send to my associate or send to the PT down the street. So making sure that I know what I treat and I know what I don't treat. Also, as far as clear expectations is, hey, you might be a little sore after your first visit, or you might be a little sore after doing exercises. Give them an idea of what is about to happen after they see you, so everything seems, or I shouldn't say seems, is expected. The next piece in my first visit, clear expectations, I would say definitely using models and visuals to explain what's wrong and how care helps. We talk about dynamic disc designs all the time. In fact, I don't think I've ever met Drum Fryer, the owner of Dynamic Disc Designs.
That's by his choice.
We're not like paid consultants. However, that model, how much do those things cost? Do you have any idea?
Whatever they cost, they're well worth it.
Yeah.
I know they're not cheap, but man, are they good. Functional and allow that, you can show a disc herniating by compressing the vertebra. Tremendous. I have no idea how they make models that look that real.
That's what I was going to say is that they're not cheap. However, they're worth it. Whatever that cost is definitely worth it. And the one that I like the most is the one that can show a patient with that little suction cup on the facet joint. And when you pull it apart, when you distract a joint, you hear a popping sound. The look
That's
on
what that sound is all day?
yeah, the look on someone's face when like, oh, that's what you're doing? Because there is a little bit of, I don't want to say magic, it's not magic by any means, but they don't know what that popping sound is. So really using models, using visuals, using infographics, and then 100% of the time, a written report of findings. Our condition report saves me more time of understanding here's what plantar fasciitis is, here's the exercise you're going to do, here's what I'm going to do, here's how long it's going to take, and keeping in mind that here's how long it's going to take is not a business plan. That is a clinical plan. When you talk about healing times, listen, bones heal 6 to 8 weeks, nerves 4 to 6 weeks, a muscle problem 5 to 7 days, grade 1 sprain 2 to 4 weeks. So when you understand the condition and what's wrong with someone, you can give a decent prognosis of understanding how long it's going to take. It's kind of like that patient that comes in that's had lumbar spine disc herniation. They've had it for 2 weeks. They come in antalgic, sweating, red, painful, teary-eyed. I'm like, oh my gosh, Dr. Steele, I know I haven't seen you in a while. However, I've got this raging back pain. It started 2 weeks ago. The family is.
Wait, they're sweating? They have back pain?
You know what I mean.
They didn't come back, did they?
but the family's packed up to go to Disney World. Like, can you just fix this real quick so I can go on my way to Disney World? I'm like, come on. It's going to take more time to heal that tissue. So unfortunately, we can't just, work miracles in the office. And then setting expectations. I say the last one that is probably the most powerful is my informed consent. And my informed consent is not signing a sheet. It's not saying, can I treat you? It's to offer realistic alternatives at the very end of it. Because if someone comes into, let's take that last patient, that if you say, listen, I can do some manipulation, some traction, some manual therapy, I'm going to give you some rehab, here's my results and here's how I do it. But I'll tell you what, John, you can also get an epidural steroid injection. You can also do a Medrol dose pack. You can also go to PT for a month and then explain the pros and cons of each one of those. I've never had a patient, when I go through a realistic informed consent, say, yeah, I'm going to try that instead. No, they're in my office for a reason. I've just never experienced that. Now, can that happen when you are not getting any kind of positive results with the patients after 6 visits? Yes. It's of course a great idea to have an informed consent and have alternatives. However, in that beginning experience, letting the person know that there are many options, but I have the option for you.
Yeah, definitely. They don't leave very often during the first visit. But a lot of them may not a lot, but a percentage of patients are not going to come back on the second visit. If they drop out of care, it's going to be the second visit or the third or the fourth or the fifth visit. And that's the second rationale that we talk about today, and that's the post-decision dissonance, which is buyer's remorse. Did I make the right choice? That feeling kicks in after someone has committed and said, yes, I'm going to schedule an appointment with this office. Did they show up? Maybe not. After they had the report of findings, did they come back? Maybe not. After the third visit when they're not feeling better, they're saying, did I make the right decision? And these missed appointments further, just so if the patient doesn't come into that third or fourth visit and they skip a couple, well, their results are certainly going to fail, and it only reinforces it. So what do? A couple of things is, number one, affirm their decision. So we have a new patient experience, letting the patient know you're in the right place. We send them a welcome kit electronically that confirms their appointment. A welcome letter from the doctor includes our curriculum vitae. When they get to the office, hopefully they're greeted with a smile, that they say, yes, this is a friendly place, one of the things that they're looking for. And if you think about going to a new doctor's office, whether it be a podiatrist or a who knows what, you're wondering what's going on behind the scenes. So one thing that we do is give an office tour. We have the staff take the patients around. This is the therapy area. Here's the treatment rooms. These are the tables. These are the types of things that our doctors treat. The thing that we do as providers to help reinforce you've made the right decision is showing the patient that we listen. That when the patient gives you their OPPQRST, which now we collect electronically through our chief complaint survey, which has been awesome because our first visit has gone from a 15-minute consult to just confirming those, I still repeat it back. So repeating back the OPPQRST, regardless of how you collect it, saying, Billy, I understand you have back pain. It's been 3 weeks. It gets better with this, worse with this. The patient will have a wow moment, realizing, if nothing else, you listened and you understand. And then we're going to give a report of findings that answers the questions that the patient needs to know. What's wrong? What are you going to do to help? How long is this going to take? And what do I need to do as part of this process? And understanding, yes, you are part of this process. It's not just the magic here in the office. We'll also make sure that we reinforce that with something to send them home with. That you can say everything in the office and they'll shake their heads. But I bet if you gave them a test afterwards, it'd be like Dr. Steele's psychology test. They might get a C at best, even if they're smart. They're not going to remember that stuff because it was overwhelming. So giving them something to take home that reinforces that they can show to their spouse with the actual language of here's what's wrong and here's what we're going to do to solve it. We'll also make sure that at the end of the first visit, there's a quick recap. And my line, just shooting from the hip because I've said it a million times, is, okay, Bill, that's what we're going to do today. We're going to start easy. Nothing I do would be more uncomfortable than what we did today. I'll warn you, you're probably going to feel a little soreness. It's like going to the gym for the first time or working out or raking leaves. That's going to fade after a couple of treatments, no soreness, and we'll see progress. It's going to take a couple of treatments, but we're going to get there. Any questions? And then the patient understands they have expectations. Okay, if I go home and feel a little worse today, I'm supposed to. That means good things. It was like going to the gym. And then we'll also call the patient after the first visit. That evening we'll I have a call list. I jump on the phone and say, hey, Bill, Dr. B, just trying to see how you're feeling this evening. If they say, I feel great, fantastic. I'll see you on Tuesday. If they say I'm a little sore, yep, that's what we expect. That's not unusual. You had a lot of restriction and tightness. It's going to be sore. Stick with it. We'll see you on Tuesday. So just letting the patient know that you cared. I think that every experience that a patient has plays into it. And when you go to a hotel, if you go to the Ritz-Carlton, you walk in and say, I think I'm in the right place, versus you go to a Hotel Sketchmore and you think, I'm not sure I'm going to stay here. Patients decide based upon all of the things, from the way the office looks to the way the staff greets them to the way that they're treated. So we want to make sure that we're giving that patient that Ritz-Carlton experience as much as we can. If you want to dive deeper into those, you can go into the marketing campaigns under new patient experience, and it kind of gives you all of the things that you need along with that. I know one of the things that you do, Brandon, is use outcome data when you talk to patients and talk to PCPs.
Well, yeah, I need to know just as much as the patient needs to know, and really the insurance company needs to go at this point. Is that what is our clinical success? What am I good at? What am I not good at? And it only helps, and I talked a little bit about adhesive capsulitis. It kind of falls outside of my get people out of pain quickly mentality. And so that's something that I don't treat, but I have a partner, another chiropractor in my office who does treat those things very well. So I think that's one of the things that will only help improve your confidence in what you're treating if you start to limit the things that you treat. And I think that's where one of the things you were talking about is, the way you communicate with a patient in between the office visits, is that one of the questions that I ask is, how are you doing today? And I'll get better, I'll get worse, and I'll get the same. And it doesn't matter. Each one of those, my response is the exact same. Great. Because if someone says I'm doing better, like, oh, then there's like, well, what do you mean, oh? And definitely with worse, the same. I will say that same, if I hear that, for the next 3 visits, that's my biggest, red flag. But really, better and worse gives you information. However, if that information is startling to you as the provider, that's not a great look, coming from the patient. So I think that the piece that I want to bring up is that make sure everything you're doing is measured and managed. Even with your exercises, did they hurt? Do they, because they want to make sure that you're understanding the work they're doing for you. And so while we use a lot of things in our office to help measure progress, like disability indices, these things matter to the insurance company, but really the results matter to the patient. So on each and every visit, have some kind of audit system, some kind of clinical audit, some kind of movement that hurt before, and you continually measure each visit to make sure you're showing them progress and make sure you're impressing that person in front of you. Meaning, yeah, I'm glad your dash score is getting better, oswestry is decreasing. Those are great things. However, most chiropractors don't know what those scores, mean. Neither does your patient. Really, can you walk better? Can you walk longer? Can you sit for a longer period of time? I think those are probably the biggest pieces. Also, make sure to keep everything in sixth grade language because it has to be digestible. Patients should never leave your office confused. In fact, a lot of times I'll ask a patient, not are you doing better? It's what are you doing today for your condition? Well, I'm going to do the exercise you gave me and I'm going to move my computer monitor. That's the response that I want to get, not a blank stare, not a I don't know. They need to understand what you're asking of them. So, final thoughts here. I know this isn't the final thought to the podcast, but really, I think that as far as my final thoughts, we need to align our treatments with their identity, meaning they want something. That's why they came to your office. Most of the time, they want to get out of pain yesterday. However, we need to set crystal clear expectations of how we're going to accomplish their problem. We're going to reinforce the smart decisions they make, like doing their exercise, like moving their computer monitor. And don't forget, compliance is not a demand. I'm not forcing compliance on them. It is a collaborative decision. They need to buy into what you are selling, and what you are selling is a solution to their problem.
Yeah, absolutely. Our communication is crucial. I think one of the lessons that we learned during COVID, when we see that you could have remote visits, telemedicine, is that a lot of physical therapy studies said patients got just about as much benefit, and that was purely words. Obviously, there was no hands-on treatment happening through the phone unless you had a really fancy system. But those words, if we can reduce the patient's regret and build trust and make them feel like they're part of the team, those results are going to change, especially our patients with chronic pain. They need to understand those things. We need to understand where our patients are coming from and recognizing that they're going to have a different level of commitment based upon that. That if you, the three ways that we get patients into our office are through relationships, through internal marketing, and through external marketing. And things that are based on relationships are the things that last. If an MD sent you a patient, or a nurse practitioner, or a PA, that patient is very likely to stick around. If they came from an internal source, you already know them, you have a relationship, you're doing a reactivation campaign, you sent them a birthday card, they read your newsletter, that's a relationship. Our external marketing, while sometimes we have to do that, especially starting out in practice, that's a disloyal patient that's ready to bolt at the first time your parking lot is full. So understanding where those sources come from and then nurturing the good ones, the PCPs and our patients, that's where putting dollars into relationships makes all the difference. We also want to make sure that we have things to back that up, because even though somebody was referred by their PCP or through their friend, they're probably going to check you out. So they're going to look at your website. They're going to go to Google. So we need Google reviews from satisfied patients. And that's our number 3 source of referrals, really, is from those Google reviews. In this digital landscape that we live in today, if you're not collecting reviews, you're not even in the conversation when patients search for a chiropractor. It's crucial to have that. You said something, Brandon, about setting realistic expectations. And I think the first visit sets the tone, letting them know that here's what I can do, here's what I can't do. And if we have a patient that we can't help, letting them know that too. That patient can't wait to find a problem to come back in, because they recognize you were there for one purpose, and that's to help them, not to help you. Number 4 would be to make sure we revisit those expectations on a regular visit. After each visit, see what the progress is compared to initially. Your range of motion is better here. Now you don't have pain when you wake up in the morning. You're lasting longer in the day before you start getting discomfort. Making sure the patient can see those steps of progress.
I know we're going to finish up the podcast with talking about the EHR. However, how easy is it now to look at what their range of motion was last visit and their pain was last visit? That has been game changing.
Yeah, just being able to see that dashboard of things are changing, which allows us to relay it to the patient. And patients want to know, we get busy in practice and we forget those things, but these subtle words that we think that are adjustments and our exercises and our nerve flossing are where it's all happening. Our words are where a lot of it's happening when it really comes down to it. And some of those words are things that patients can use too. Patient education tools, giving them visual and verbal explanations of their diagnosis. They want to know those 4 things. They want to know what the plan is. They want to know what to expect as far as an outcome. What is our goal? What will constitute success, so that we're all playing with the same scorecard. And then lastly, I think owning it before you sell it. that as a provider, as I've become more confident over time, and I'm still learning, by no means do I want to relay that I have the answers. I don't have any more answers than anyone else does, but I have a lot more answers than I did years ago. And being able to own that with clinical confidence, that when you see a patient who has some radiating pain into their thigh, you understand, well, it's myalgia paresthetica, or maybe it's something else.
Okay, so that's funny that you bring that up because did you see that article? I think it was no, it was yesterday or
So,
today.
so that was called a lead in.
Uh, so we just talked about this article. So I do want we're going to cover. I think I want to cover 5 questions in our outline about the EHR. But before I do that, I'm glad you brought that up because no, before the podcast we were talking about this. Have you ever had a patient that has dysesthesia on the lateral, more the anterior lateral part of their thigh, and I've always thought like myalgia paresthetica, like it's pathognomonic. And then for 10, 15 years, I've been like, man, this doesn't make sense. Like for my pregnant patients and my overweight patients or police officers with tight belt, it did make sense. But I was like, well, that doesn't make any sense. And then you go about doing your business and you find out they have gluteal tendinopathy. There was just an article in the Clinical Journal of Pain on this, and that 30% of patients with painful tendinopathy at the gluteal tendon have neuropathic-like symptoms. So when you start to have long-standing issues with that tendon, they will start to get not muscle tendon pain, they will get neuropathic symptoms like numbness, tingling, and that kind of stuff. So I just thought that was interesting. Thank you for providing that lead in. You know what? Sometimes you read a research article, I'm like, well, that makes sense. I wish someone would have told me that a long time ago. That's 15 years of confusion that just got summed up in a 3-minute research article. Anyway, let's finish this podcast out. This is the most, I always say most exciting because,
Yeah,
one of the things
because
that
you have the questions.
my wife was talking about a chiro not too long ago, and she said, "What's your tagline? Like, what's your motto?" And I gave her the motto that we have, and she said it should be "What's next?" Like, chiro, what's next? Because every time I go home, there's like something next. Like there's something else that we're doing. So I thought this would be fun at the end of this podcast to give you a couple questions to kind of understand where we are right now. Now, keeping in mind we're in the middle of April when this podcast was recorded, but let's go through a couple questions because we just surpassed our first 100 EHR subscribers, and so Tim, if you don't mind, off the cuff here. What's it been like seeing 100, well, I shouldn't say 100 because we're seeing about 1.5 chiropractors per office, which is kind of interesting. So 100 chiropractic offices jump on board and what we're classifying as our early adopters, the first people to jump on, to trust us, and to help build this for the profession.
And we know who the half chiropractor in our office is. Actually, that's a great question. It's really been humbling that a lot of chiropractors took a leap, and while we were using it in our office for several months, we didn't know what would happen in other offices. So those early adopters, the Dr. Muma and Manwaring and Kippenberger and lots of other names that we should mention, thank you for trusting us when it was fresh out of the gate. And the 100 providers who have given us unbelievable feedback. They've had patience, but they've had belief. These are not users of the system. These are owners of the system. These are people who didn't want to buy the perfect EHR. They wanted to build the perfect EHR. And we've really come a long way in that process. So thank you for that. I would say humbling to those subscribers who really shaped the platform into what it's today, and more importantly, what it's going to become in the years to follow.
And I think one of the most nervous weeks of my entire life was actually not releasing the Chiro EHR. I was actually releasing the Chiro Essentials product. Do you remember how you felt? I think it was Indiana, right before it was our first time speaking to a non-friendly crowd because we'd spoken for Illinois before. But do you remember how you felt the first time that you and I went to sell this new product? We went to show everyone our baby.
Yeah. First, we should clarify the non-friendly.
Well, yeah.
We were very involved in Illinois, so we knew everybody there. But going to a state where we didn't know everybody, and they were obviously just as
Correct.
Yeah, we've talked about this a few times that, you're building and you're like, this is awesome, everybody's going to love it. And then when it comes down to the wire where it's time to sell, you're like, what if nobody buys this thing, that we're going to be stuck with all this coding? Unfortunately, that's not been the case. Now we've got 3,000 chiropractors in 16 countries who are using the Essential system. And it taught us a couple things. Number one is that we all wanted better tools, that we're trying to do audacious things, and we didn't have all the tools we needed. And it also taught us that building something worthwhile is not easy. You remember when we started the EHR, we said, about 11 months. We'll be just talking in January. It'll be done with one coder in November. Well, it didn't exactly go that way. Now we had 8 people on the coding team, and it was 2 years to get the minimum viable product out. Now they're really putting some polish on that one. So I think those would be the 2 lessons that I've taken from that.
What about, as far as the like, what surprised you the most? When people started using the system, what are the uses of the system? What are the things that you've heard back as far as feedback that kind of surprised you?
Well, this shouldn't be a surprise that chiropractic practices are different. And even amongst evidence-based chiropractors, they do different things, different billing, multidisciplinary setups. Some are cash, insurance, unique workflows. And it really made us design an EHR where everything was still integrated but accommodated those. We didn't want a patched on system that when you take a note, it had to talk to the bill, the schedule had to talk to the note. So all those things should not be independent. There should be no redundancy, and making sure that it worked with all those unique workflows. That was it, making sure that system could flex with how we needed to use it in practice for each of us.
Yeah, and we built the first system based on subscriber feedback, meaning we built it for us, and then we got more feedback from people, and then it morphed into what it was, and what it is. So what's been the feedback from our first, early adopters?
As far as the overall feedback, I would say that the SOAP note is the one thing that's outstanding. As I said, we had released this minimum viable product, as every software company does, and the SOAP note was far beyond that, and we had been using that for a long time as well. And I think that the unique part is that from our subscriber interactions, from that focus group of those dedicated people who helped us put this together, we realized that if we built it for the workflow, that a typical SOAP note, SOAP, is not the right order, because chiropractors typically will see the patient, they'll review the S, then they'll put their hands on the patient to assess them and treat them, and then go do the note. Well, by the time they do the note, they know the assessment. And if you knew the assessment, then you probably know what tests you did for those diagnoses and what treatments you would do based on your protocol. So that's what we've done, is leveraged your best practices in ChiroUp, that once you put in the diagnosis of lumbar stenosis, we know that you probably did Sphinx test. We know that you probably had discomfort with extension. And so those things can auto-populate. The provider can quickly go through and say yes or no, accept them all or not. And the same thing with the treatments, and the note is done. And I think that that's been the biggest thing. I remember the subscriber, the one time that was probably most impressive is when, and this was maybe a month ago, I was in Arizona, and so I saw it on Slack. And she said, this was day one, she said she was in tears. Her notes are done. First day in a long time that she could pick up her kids from daycare and go to the gym. And that was huge. That was the life-changing moment. So I think that would be the biggest win.
Yeah, I think that really many people don't know our staff. However, our dev team, Jeremy leading the coding, leading the coding team, Emily leading the architecture. Her attention to detail is scary, how good she is at knowing every aspect. Kara keeps every detail line. And I know you don't know these people as podcast listeners, but these people are pushing updates and our dreams fast. And to go into the what's next idea, is there's one feature that's already built that we've been using for 2 months now, that we really can't even talk about yet. But let's just say, if you think our notes are fast, or you think your notes are fast and complete, this is going to blow your mind. So just a bunch of fun things with some really great people at ChiroUp, which we've always had, but our team keeps on growing.
So you realize you just mentioned Kara, so you're going to want her to hear that, and then she's going to hear the thing that she said. Make sure you don't mention this until we release it.
Oh, true. I guess I shouldn't have brought that up. We'll have to edit that one out. So last 2 questions. So really looking at what now, 6 months now, how would you sum up what the EHR represents? Why are we doing this?
It's because it's not just another EHR. We didn't need a 50th or however many there are out there of something that got part of the job done. We needed something that was going to advance our profession. That when you and I started this, we weren't software developers. We were people who just had a mission to move the profession forward. We worked with our state association. We saw that as insurance reimbursement changes, it's going to be a matter that we have to make sure that our providers have evidence-based care, that they get results, that they can prove that they're doing well. And we needed to lead everybody in that direction, and a lot of people wanted to move in that direction. They just wanted the tools. So I think that was it. That we're not building an EHR. We're changing our profession together, and certainly we couldn't do this as just a company. We're doing this as a co-op, and together we're going to have a revolution.
Yeah, so if anybody wants more information on that, please schedule a demo. It's something that I think is going to change the way you practice. All right. At the end of this one, something a little bit different, but once again, the reason we have these conversations is because of the feedback from our listeners. So we had the most feedback. We had 20 responses back over the last couple podcasts on patient compliance. So we're gonna be compliant with our feedback. So if you like these kind of podcasts, let us know. Give us some more ideas on what we can cover in future podcasts. And then, of course, if you've enjoyed this episode, share with a friend, share with a colleague. Really, if you can get inspired by this and you find this information valuable, please give us that valuable feedback because it helps us grow as podcast presenters. And it's all about pushing the profession forward. And if we can help spread this message, we're going to do it, and we're going to hopefully answer your questions. And one thing you can do for us is to hit that follow button. It helps us get heard by more chiropractors looking to do things right.
Hey, thanks for listening. To access more information, visit chiropractic.com. You can sign up for a 14-day trial. Use referral code podcast15 for a special discount after your trial. Offer valid on new subscriptions only.